Thank you very much. Thank you very much. So, good afternoon, everybody. My topic today is establishing valvular heart disease in developing countries. Okay. So I'll be looking, I guess, here, right? So, as you all know, the prevalence of rheumatic heart disease remains very high, especially in low and middle income countries. And because currently more than more people live in these low to middle income countries than in high income countries, rheumatic heart disease continue to represent a very large proportion of the growing global epidemic of valvular heart disease. Unfortunately, in countries with the highest prevalence, there is a very large gap between the patient in need for valve interventions and the actually performed procedure. And especially in the lowest income countries, the adoption and the utilization of valve interventions remains very, very low. And the question that I would like to address today with you is whether establishing dedicated valvular heart disease programs in developing countries would help address these challenges and unmet needs. The points I'm going to address are, do we really need dedicated valvular heart disease programs? And if we do, what are the challenges that we expect to face? How to promote transcatheter therapy? And what is the position of research within that landscape? I'm a clinician, I'm an intervention cardiologist, I have no administrative experience whatsoever, so I'll address all of these points from a pure clinician's perspective. I'll leave the floor to other speakers who would address other societal and administrative aspects of these challenges. So the first question, do we need dedicated valvular heart disease programs? The answer is an unequivocal yes. It's been for years, for decades, to address valvular heart disease patients in a multidisciplinary, structured way. But the most recent evolution of this concept has been triggered by the appealing TAVI heart team model. And the recent guidelines have taken this concept of heart team to another level, making it the very center, the very backbone of the heart valve center. In this model, networks of referral are connected to super specialized centers through heart valve clinics in order to facilitate complete and integrated multimodality imaging and multidisciplinary decision making. So what will happen if we adopt these models in our developing countries? What will happen? What are the challenges to expect? Of course, major financial and technical constraints with resultant limited access to the more sophisticated therapies, a high or at least moderate prevalence of rheumatic heart disease with important implications on management, and a large proportion of patients who are young. And these young patients have their own special needs. They need durable solutions, and they need a philosophy of reducing the lifetime number of interventions. And many of these are females in the childbearing period with very important implications on management again. What I would like to share with you is our young and early experience at Al-Azhar University. It's a tertiary center in the very densely populated capital of Egypt, Cairo. The center is composed of a dedicated heart valve clinic, integrated multimodality imaging, multidisciplinary decision-making between the cardiologists, imagers, and surgeons to identify suitable candidates for surgical as well as transcatheter therapies, and eventually some registries, prospective and retrospective, running in the background. Multimodality imaging is actually a cornerstone of our program. And the major target of this arsenal of imaging modalities is to guide decisions and guide procedures. So for several conditions, there are standardized, established algorithms to do imaging. And for other more challenging dilemmas, we are regularly synthesizing tailored algorithms to address these conditions. We also have a very ambitious transcatheter therapy program, which is expanding to include a spectrum of transcatheter techniques. And percutaneous mitral commissurotomy, or PMC, continues to be the most frequent procedure we undergo on a weekly basis, so 3-4 cases a week. And although this procedure has served hundreds of thousands of patients worldwide for decades, what we are observing recently is that the profile of patients is changing to older, more morbid, and less suitable anatomy candidates. And this is just one example of what we are now seeing every single week: patients with prior interventions and very advanced pathology, heavy calcification, difficult anatomy to tackle. And the implication of this is that what we have observed recently, that the success rate is going down. So contrary to all cardiac interventions that is going up, the success rate of PMC is going down. And what I would like to share with you is to walk you through some of the interventions and investments that we are trying to implement in order to secure high success rate in spite of this unfavorable profile. Take an example of this 32-year-old lady who came with restenosis after mitral commissurotomy 9 years earlier. She's now symptomatic with moderate elevation of pulmonary artery pressure. She had recent abortion for which mitral stenosis was blamed, and she's now contemplating another pregnancy. And as you can see on the first slide, that the anterolateral commissure is completely split, which precludes any meaningful commissurotomy. But more careful analysis of the 3D images shows you here that this commissure is actually partially fused. Very successful, very helpful mitral commissurotomy was performed 2 weeks later, and the lady is now expecting her child. So in addition to very dedicated imaging and wise decision-making, some technical refinements may be required in order to get the job done. Like this example, when we, off-label, of course, use deflectable ablation catheters to cross the mitral valve to make the procedure feasible in this patient with very, very challenging anatomy. Sometimes we go back to old school in order to get the job done, like using double wires, the very old school. Using these investments, technical imaging, so blah, blah, to improve outcome has enabled us to improve our success rate in spite of very unfavorable profile of our patients. And this is just a snapshot of our most recent experience of 130 patients in whom only 40% of patients had ideal anatomy, even though success rate was secure in almost 90% of cases. TAVI for rheumatic aortic stenosis is another uncharted area with only very pilot observational data suggesting feasibility and safety. And what we are observing, which is not there in the literature yet, is that we are observing a mixture of anatomies, a mixture of pathologies. So older patients are now having rheumatic and degenerative aortic stenosis. So a mixture of leaflet thickening and degenerative calcification is becoming a very frequent observation. In this particular patient, who was a 74-year-old gentleman with severe symptomatic aortic stenosis, it caused functional bicuspidity eventually. And the calcification was severe enough to cause balloon valvoplasty to rupture and to impair initial valve expansion, which was eventually ameliorated with stepwise post-dilatation. But what we need to expand TAVI more and more in developing countries, there are certain aspects that we should consider, including the realization that TAVI remains a much more expensive alternative to surgery, more so in developing countries, where the price of the device represents the very big portion of the costs. This calls for an even more efficient cooperation between the surgeon and the cardiologist to identify patients who would benefit most from TAVI and reserve it to patients who don't have surgical options. Technically, TAVI programs in developing countries should focus on one or few economic platforms of TAVI. And eventually, we need to implement more and more research in order to realize the real burden of aortic stenosis and the very special pathoanatomical profile of this disease in our communities. Transcatheter closure of PVL is a cost-effective procedure. It can reduce the lifetime number of surgeries for our patients with rheumatic valve disease and bicuspid valve disease who usually undergo surgery early in their life. And although surgery has been standard for decades, it carries an inherent high risk of perioperative complications because it's a redo surgery, and of course, a higher likelihood of recurrences in the future. The more appealing transcatheter option can be demanding in terms of planning, in terms of execution. And I'll take this example to demonstrate how we tackle mitral paravalvular leaks. 3D TEE is standard to evaluate the severity of leakage and the location, size, and shape of the defect. The procedure itself is basically TEE guided under general anesthesia, which requires very efficient communication between the interventionist, the echocardiographist, and the anesthesiologist. And transeptal puncture is basically guided by TEE, while further procedural steps are requiring integrated images between fluoro and echocardiography. Sometimes it's straightforward. It's anti-grade transeptal procedure using a single device that totally eliminates paravalvular leakage. But in other cases, it can be much more complicated. And the key for success in these challenging scenarios is to have a complete plan before going to the procedure. So in advance, you have the plan set up. So in order to have this plan, you need to localize the defect, to know its shape and its size, because this will dictate the approach, the number, the shape, and the size of the device. Because this will take you to alternatives to the previously mentioned straightforward scenario. It can take you to AV rails for an approach, or even retrograde transaortic deployment of the device. It can tell you in advance that your very well-coapted device that will seal the defect will eventually interact with the mechanical valve leaflets, so you should avoid using that device. And it can tell you in advance that you should preemptively deploy 2 devices simultaneously to get the job done. Aortic paraleaks can be technically less demanding, but in terms of imaging and assessment, it can be a nightmare. And most of the times, echocardiography fails to provide comprehensive evaluation, even using 3D TEE. And what we are now adopting systematically is to complement these echo data with CT data. So in this particular patient, only CT could enabled us to accurately define the location, the shape, and the size of the defect. It also helped us appreciate the relationship between the leak or the defect and the adjacent structures, and the orientation of the mechanical valve leaflets in relation to the defect. Furthermore, it enabled us to plan our fluoroscopic projections of the procedure in advance. And what we do is that we draw all these things in one cartoon, complement all data, compile them, and take them to the cath lab, which in this particular patient helped us complete the procedure, which was successfully performed using 2 PDA occluders, because vascular plugs are not reimbursed in Egypt right now. And as you probably have noticed, and as what we have been learning year after year, is that when you master a procedure, it actually paves the way for another procedure. So the skill set you master in a certain intervention can be of tremendous help in introducing new techniques. A last word on research, very quick one. How would research thrive in such a challenging atmosphere? It's simple. It's even with modest but consistent archiving of data, we can address the clinical questions we face in our practice in a scientific manner, which yields eventually very meaningful research. And in our case, we focus on the role of multimodality imaging in the evaluation of valvular heart disease, and explore some novel concepts such as whether contrast CT would help us predict the outcome of percutaneous mitral commissurotomy. In addition to these smaller scale mechanistic studies, we run some larger scale registries that would help us improve our understanding of valvular heart disease in our communities. And to conclude, valvular heart disease programs are needed in developing countries. They are feasible, but they have their own characteristics and challenges, as well as their own objectives. The prevalence of rheumatic heart disease remains high in middle and low-income countries, but a mixed pattern of pathology is now gradually prevailing. Contemporary mitral commissurotomy candidates are more challenging, calling for continued refinements in order to secure success. cumulative experience is a natural progression of any dedicated program, as is research, which is another natural product of an organized program. And thank you very much for your attention.